That concludes components 1 and 2, identification of the jugular venous pulse and quantitative assessment of the jugular venous pulse. We are now ready to move into component number 3, which is qualitative assessment. Now, this is, and again, please feel free to fire off questions. We'll go back and try to answer these questions at the end. This is a bit more sophisticated of an endeavor where we're actually evaluating the waveform itself. But it's amazing how much you can learn about the heart by looking at the waveform. And to illustrate that point, I'll ask a question. What is Mobitz 1 heart block? I think we would all answer this question electrocardiographically. We would define it as PR prolongation before drop QRS complexes. And you would be right if you described it that way. But what if I told you that Wenckebach described Mobitz 1 several years before the EKG was available to him? How did he do it? Now, this is a talk on the jugular venous pulse, and if you're thinking just then that he must have used the neck veins, you'd be absolutely right. The question is, how did he use them? And hopefully at the end of this component of the talk, I'm sorry? It'll become clear how he used the neck veins to accomplish this. Before we can talk about abnormal waveforms, we have to be intimately familiar with the normal waveform, each component of the normal waveform, and what cardiac events cause each component of the waveform. So let's start with the A wave, the first peak in the waveform. The A wave is caused by right atrial contraction. So obviously as the atrium contracts, that's going to generate an increased pressure within the atrium, and that's going to be a positive wave in the waveform. That's the A wave. That's going to be a peak. When does right atrial contraction occur? It occurs at the end of diastole when the atrium is trying to squeeze that last bit of blood into the right ventricle. And it's important to orient yourself early on to the cardiac cycle here. At least it is for me. It's very helpful because now I can sort of use that to my advantage, and I can go in order and just try to sort out, and it helps me remember the next components of the waveform and what causes them. So we're in late diastole. Now we're in early systole. And what happens in early systole? Well, we have isovolumetric contraction, where the ventricle doesn't quite mechanically contract yet, but the pressure builds up, and that's going to slam the tricuspid valve shut. And when the tricuspid valve slams shut, it bulges into the right atrium, and that causes a little pressure blip known as a C wave. Now, the C wave is not visible at the bedside. After early systole, we're in the middle of systole. And what's going to happen after isovolumetric contraction? Well, now you have actual mechanical contraction. And when the ventricle contracts, it squeezes and twists and contorts down towards the apex. And when it does that, it creates a mechanical event where it pulls the floor of the right atrium down towards the apex. And when that happens, it pulls a column of blood down. At the same time, the atrium has just contracted at the end of diastole, and now it needs to relax. So now the atrium is relaxing, and that's going to cause the pressure to go down. So the combination of right atrial relaxation and mechanical ventricular contraction causes the X descent. Now we're in late systole, and the atrium just relaxed. Why did it relax? Well, it relaxed because it needs to fill with blood again, so this whole thing can start back over. So when the RA begins to fill with blood, volume implies pressure, and as it's filling with blood, volume and pressure go up, and you get the V wave. Now we're done with systole. Now we're back in early diastole, and in early diastole, what's happening there? Well, the tricuspid valve springs open, and now you have passive ventricular filling from the right atrium. And obviously, as the right atrium loses that volume of blood, pressure will also go down, and that's going to create the Y descent. It is critical to have an intimate understanding of the normal jugular venous waveform and the cardiac events that cause each component of the waveform. Let's revisit this video from earlier in the talk, which is a normal jugular venous pulse. And many people will tell you that you can't visualize the individual components of the waveform at the bedside. It's a whiteboard phenomenon, and don't bother looking. Well, that's just simply not true. And this is a great example of that. So here we can see, and Joe has created this video where he's put the tracing over the top of the video, and you can follow that cursor along. And I think all of us can, at the very least, appreciate the descents. And again, that's what's going to catch your eye in the venous waveform, are the descents. So we've got X, Y, X, Y. And if I slow this down to quarter speed, here we go. So we've got A, X, V, Y, A, X, V, Y. So the descents will catch your eye. The peaks are somewhat passive, hard to notice. And but you can absolutely see the individual components of the waveform at the bedside. Here's another video with a trick using a Q-tip to demonstrate the individual components of the waveform, and Joe has annotated this for us as well. I cannot overemphasize how important it is in any part of the cardiac exam, whether it's cardiac auscultation or evaluating the jugular venous pulse, to understand where you are in the cardiac cycle. You want to know, because if you're looking at the waveform in a vacuum, it's hard to say, is that peak the A, is it the V, is that trough the X or the Y? So when I'm evaluating the waveform, you will often see me simultaneously palpating a pulse or listening to the heart, because I'm trying to find a frame of reference for myself so that I can correlate things with the waveform, and I can understand, is that the A or the V, or is that the X or the Y? And there is one cardiac event in particular that's very helpful to orient yourself, and that is S1. We know that S1 is associated with closure of the tricuspid valve. It's also going to occur at the same time as the peripheral pulse. And what component of the waveform is caused by tricuspid valve closure? Well, we just went over this. That's the C wave. Now, you don't see the C wave at the bedside, as we mentioned, but it's right in the middle of the X descent. So the X descent is going to occur at the same time as S1 and the peripheral pulse. So if you're looking at a trough and you want to say, and you can't tell, is that the X or the Y? You can feel the peripheral pulse, or you can listen to the heart. And if it's occurring concordant with those events, that is the X descent. If it's discordant with those events, that's the Y descent. Let's revisit this video from earlier in the talk, where we have an arterial pulse and a venous pulse just side by side. And let's look at the venous pulse for a moment. There are two troughs here, but one is dominant. Right there. 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 What if I asked you, is that the X or the Y, and how could you tell? Well, if you had the benefit of being at the patient's bedside, you could do what we just talked about. You could feel the pulse, you could listen to the heart and correlate it. If it was concordant with S1 and the peripheral pulse, that's the X. If it was discordant, that's the Y. And we don't have the benefit of being at the bedside, but we do have this arterial pulse right here next to it. So if we can correlate this with the arterial pulse, we can tell. And if you look at it closely, that major descent, that dominant descent, is occurring at the exact same time as that arterial pulse. And so that tells us that that is the X descent. Okay, so now we are ready to talk about some abnormal waveforms. So here is the normal waveform, the top strip here, and that we're all familiar with. And the bottom waveform is abnormal. And so let's discuss what's abnormal about this waveform. So, well, we've lost our A wave. Okay, we have no A wave in this tracing, and our X descent is tiny. Remember, normally the X is more dominant than the Y. So we've lost our A, and we've mostly lost our X. And so we have to go back. We have to go back to what cardiac events cause the A wave, what event causes the X descent. For the A wave, it's right atrial contraction. The X descent is caused, at least in part, by atrial relaxation. So what condition is there an absence of coordinated atrial contraction and atrial relaxation? Well, that's atrial fibrillation. So this is a classic waveform of AFib, and will also be irregular. That's another clue. And what you'll see at the bedside here is you'll simply see a Y descent. You don't really see the C, the X, the V, you just see a descent. Okay? The next abnormality that we're going to talk about is the giant A wave. The A wave here is larger than normal. Okay, so again, what causes the A wave? Well, that's right atrial contraction. So what would cause the pressure to build up higher in the right atrium than it normally would? Well, that's going to be any resistance to RV filling, and that's going to occur as a result of tricuspid stenosis. It's going to occur as a result of elevated end diastolic pressure within the RV from something like pulmonary hypertension. Okay, so you're going to see at the bedside, you're going to see a peak that will catch your eye. And remember, that should automatically clue you into something is not right about this waveform, because normally I don't see the peaks very well. But if I see a peak, if it catches my eye, that tells me that something is abnormal about this waveform. After that peak, you're going to see two troughs. That's important. In the giant A wave, the subsequent X and Y troughs are preserved. Okay, that'll come up later. The other thing that's important is that the giant A wave occurs with every beat. That's also something to keep in mind. Okay. Let's move on to the next abnormality, which is the Cannon A wave. Now, this is larger than the giant A wave. It's more of like a shock or ripple up the neck. And so what's worse than contracting against a stenotic tricuspid valve? Well, it's contracting against a totally closed tricuspid valve, which can happen with atrioventricular dissociation. The atria and ventricles are kind of operating at their own rhythms, And every once in a while, the right atrium is going to contract against a closed tricuspid valve, and it creates, as you might imagine, this giant sort of shock-like wave up the neck, and that's a Canon A wave. Canon A waves, now again, the Canon A wave is typically going to be intermittent, and in between the intermittent Canon A's, you're going to see the normal waveform. There are certain circumstances in which it is occurring with every beat, but for the most part, it's going to be intermittent, and that can help you distinguish it from the giant A, for example. The next abnormality to discuss is a CV fusion wave. This is also known as Lancisi sign. And again, we have to go back to the normal waveform. What's going on here? So we've lost our X descent, and what has replaced it is a CV fusion wave. So we get this large outward wave here where the X descent would be, and then we get an augmented Y descent. And this is associated with tricuspid regurgitation, and it makes sense. The X descent is occurring with ventricular systole, and that's when the atrium is also trying to relax. So if instead of relaxing, it gets this giant regurgitant bolus of blood from the ventricle, that's going to create a huge positive pressure wave in the right atrium, and that's what you'll see. You'll see the CV fusion with an augmented Y descent. You may see at the bedside, what you're going to see is you may see a little bit of an A, but for the most part, you see one wave, one trough. Now, unlike the giant A wave, this is followed only by a single trough. You lose your X descent, and that can be very helpful in distinguishing the two of them, in addition to the fact that they're occurring at different parts of the cardiac cycle. So remember, knowing where you are in the cardiac cycle is really crucial. The A wave is going to be at the end of diastole. CV fusion is going to be right in the smack in the middle of systole. And that's what you'll see at the bedside. And again, it's occurring with every beat. The next abnormality to discuss is a sharp and deep Y descent known as Friedrich sign. So what is the normal Y descent caused by? Well, that's an early diastolic event where you have passive ventricular filling. And the Friedrich sign is associated with restrictive cardiomyopathy and constrictive pericarditis. So the way I think about this, and why is it sharp and deep? Well, the pericardium is sort of around the heart, and it's sort of unyielding, it's scarred down, and the ventricle can fill only so much before it runs into that unyielding pericardium. And so all the filling has to happen early in diastole before it runs into that pericardium. At least that's the way we sort of think about it. And that'll give you a sharp and deep Y descent. Some patients with constrictive pericarditis also develop a sharp and deep X descent in addition to the Y. And it's called the W sign because if you trace this out, it looks like a W. Why some subset of patients with constriction develop both a sharp and deep X and Y rather than just Friedrich sign, unclear, but some of them do. And this is a finding that's more specific for constriction. The last tracing that I want to get to before we get to the quiz is Kussmaul sign. Here you have a paradoxical rise in JVP with inspiration. And remember, when we take a breath in, we decrease our intrathoracic pressure. And not only is that column going to suck down towards the heart to cause the normal decrease in JVP with inspiration, but you're also bringing blood from the legs and elsewhere back to the mediastinum. And if there's an issue with RV compliance, if the RV can't accept that increase in blood flow from the legs and elsewhere, that blood has nowhere else to go but up the neck. And that's what causes Kussmaul sign. It's not a very specific sign, but it's sensitive. It's sensitive to RV compliance issues from RV failure, tricuspid stenosis, constriction, restriction. So let's talk about, or let's move to the quiz mode of the talk here. And here we're going to show some videos of neck veins and try to figure out what is the qualitative abnormality that we're seeing. Before we start, I want to say a few things. First, assume the movement that you're seeing in the video is venous. That's first. The second thing is this will be challenging. It will be hard. And the reason it's so challenging in large part is because we don't have the benefit of being at the patient's bedside to do those strategies that we talked about earlier to understand where you are in the cardiac cycle. But, you know, when you look at these videos, I want you to think, what catches my eye here? Is it a peak? Is it a trough? If it's a peak, as we already mentioned, that should automatically suggest that something is not normal about this waveform. And then you're dealing with, is it a giant A? Is it a CV fusion? Is it a Canon A? You know, if it's occurring with every beat, that makes a Canon A wave less likely. So then you're dealing with a giant A versus CV fusion. Well, then from there you say, okay, how many troughs are there? Are there two troughs? In which case it's probably a giant A wave. If there's a single trough, that's CV fusion. The other thing that you should pay attention to is respiratory variation. So does the JVP vary with respiration? And also pay attention to whether the pulse is regular or irregular. Those things will help you. The last thing I'll mention is that there are some repeats. So just because we see a diagnosis once doesn't mean we won't see it again. So with having said that, let's move into our quiz and show some videos. So again, try to think, what catches my eye here about this video? Is it a peak? Is it a trough? What am I seeing? And I'm just going to kind of talk through this. You guys can feel free to type in the answers as you think of them. And I'm just going to talk through it. So what I see is I see a single outward peak, and that definitely catches my eye. And so I know automatically that this is not a normal jugular venous pulse, because the peaks aren't so conspicuous normally. They're hard to see. And Sahan is exactly right. This is CV fusion. So when we think about this, we say, okay, there's a peak that catches my eye. So I know I'm dealing with a giant A, CV fusion, or cannon A. Well, it's happening with every beat. That makes cannon A less likely. And plus, it's not a shock-like. It's sort of more of a rolling kind of wave up the neck. And that's not exactly how a cannon A wave looks. So now I'm dealing with a giant A or CV fusion. And the next question we want to ask ourselves is there one trough or two following this wave? And I see one single trough. And so this is consistent with CV fusion. This is a gentleman with severe tricuspid regurgitation from dilated cardiomyopathy. And here's the annotated video that Joe has made for us showing the CV fusion and the big Y. Look at that Y descent. Let's move to the next video here. Feel free to type in your answer as you see it. So as we observe this neck, what do we notice? Is there some kind of respiratory variation? So here's the annotated video. You can see the JVP in the middle of the neck as the patient takes a breath in. Yeah, Bruno, that's right. It's Kussmaul sign. So as she takes a breath in, there it goes, all the way up the neck to the angular jaw. Look at that EJ fill. It's like a worm in the neck. And this is Kussmaul sign. This patient also has another finding as well. So if you look at those X and Y descents, they look rather sharp and deep. She has a W sign as well. And this is a patient with constrictive pericarditis. She actually developed it. It's a rare sequelum after orthotopic heart transplantation. And so she developed constriction 20 years after that procedure. Let's look at the next video here. And again, think to yourself, what catches your eye here? Is it a peak or is it a trough? What catches my eye is a trough. I see a trough right there, there, there. There are several troughs, but one in particular is quite larger than the other. And so I want to know, is that the X or the Y? Now, if we were at the bedside, we could utilize those strategies we discussed and feel the pulse, listen to the heart at the same time, and try to decide, is that concordant with those events, in which case it would be an X descent, or is it discordant with those events, in which case it would be a Y descent? And I can tell you that this large descent here is discordant with the pulse and with S1. It is consistent with a Y descent. This is Friedrich sign. So there you go. You see a little bit of an X and then a big Y. So here we go. So a little X, Y, X, Y, X, Y. And this is a gentleman who came in with tamponade and developed a phenomenon called transient or subacute constrictive pericarditis, which I wasn't familiar with before this case. I always thought that constriction was a permanent thing, but it can be subacute and transient. And his findings of constriction disappeared after a few weeks. So let's move on to the next video here and ask yourself, in this video, what is catching my eye? Is it a peak or a trough? What do you guys think? What do you notice here? Peak or a trough? What catches your eye? Yep, absolutely, Bruno. There's a peak here that catches your eye, and that should immediately make you think that something is not quite right about this waveform, because the peaks in the normal jugular venous pulse are not conspicuous like this. So we see a peak, and so then we're back to our sort of differential. Is it a giant A? Is it a cannon A? Is it CV fusion? And how many troughs do you see? So it's occurring with every beat, so less likely to be a cannon A. So we're thinking giant A or CV fusion. How many troughs do you see following that peak? Yep, 2 troughs, exactly, Jorge. So this is a giant A wave in a young woman who developed pulmonary hypertension as a result of methamphetamine use. So here we go. So we can really see it. We can follow that tracing along. So here we go. A, X, V, Y, A, X, V, Y, A, X, V, Y. That's quite an impressive A wave. Let's move to the next video here. So what do you notice? Anyone know what this is? Is there some respiratory variation here? So there's the JVP, and when he takes a breath in, look at it climb all the way up the neck to the angle of the jaw. This is Kussmaul sign. What else do you notice about this gentleman's skin? What is this mark right here, right below the A wave in our logo? Anybody know what that is? That circular mark there? Yes, Mohammed, that's exactly right. This is a radiation tattoo. And how can you put that together with Kussmaul sign? Well, this gentleman had Hodgkin's lymphoma when he was a teenager, had radiation to the chest, and that led to constrictive pericarditis. Great job. All right, let's look at the next video. This is perhaps my favorite video. So what do we notice here? There's clearly a peak that we can all see. And there's clearly, then the next question is are there two troughs or one? There is one. This is an augmented Y descent following CV fusion, and a gentleman with severe TR, which was an iatrogenic complication, actually had a catheter that damaged his tricuspid valve and causing severe TR. Okay, so for this next video, I'm going to put the annotation on because it's very difficult to tell where she is in the respiratory cycle. We did not talk about this during the talk, but here we see the JVP way up there with expiration and way down here with inspiration. And you might be thinking, well, that's normal. The JVP should go down with inspiration. You'd be right, but not quite to this degree. This is marked respiratory variation. This is very dramatic. It should go down maybe a couple centimeters, but to go down, this is going down at least 12 centimeters here. This is marked. Anybody know what condition is associated with marked respiratory variation in the JVP, where you get a pseudo elevation during expiration or exhalation? Anybody know what condition? Pulsus paradoxus. That's a good guess, because you can get pulsus paradoxus for the same reason from lung conditions like asthma. And this is somebody with lung disease. And the reason is because during exhalation, they generate quite elevated intrathoracic pressure, and that's going to drive the JVP up. And when they take a breath in, they create really large negative intrapleural pressures, and that pulls the JVP down. So you can I put this in here because it's important. You can get fooled by the pseudo elevation and think that this person has a markedly elevated JVP. She's in the upright position, and I've been fooled by this in the past. So I figured it was high yield to put in here. What is this? What do we see here in this neck? So what I notice here is I see just a trough. Boom, 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 boom. I don't really see a peak very well. I just see a single trough, and it's not really happening in a regular rhythm. This is irregular. I just see a Y descent. This is a classic AFib. We've lost our A. We don't really see the C, X, V at the top. We just see a Y descent. And again, it's irregular. Sometimes you can get fooled. Sometimes when the beats are close together, you might think this is an X followed by a Y, but in fact, it's two Ys that are close together. So this is classic AFib. What do we think about this video? What do you notice here? Anybody know? Jorge, I know you know. You got it, Mohammed. This is Kussmaul sign. So another example of Kussmaul's. Look when she takes a breath in, how these veins engorge near the angle of the jaw. Look at this one. What do you guys think this is? It's another case of one single dramatic wave followed by one single dramatic descent. This is another case of CV fusion. You got it, Mohammed and Sahan. Nice job. This is severe TR causing CV fusion. I have never seen the facial vein involved before this patient, and I have not seen it since, but here it is. And we're almost getting to the end here. This is a tough one. What do you notice when you look at the movement in this video? What catches your eye here? Is it a peak or a trough? To me, I see a peak that's a little bit more impressive than normal. It's a little bit more conspicuous. And this is a giant A wave where you have the big A, so A, X, V, Y, A, X, V, Y, A, X, V, Y. So this is a young man with tricuspid stenosis who developed giant A waves as a result of that. And here they are. So look at that A. It's really impressive. Boom, down, V, Y, A, X, V, Y. And this is another example of Kussmaul's sign here, where the patient takes a breath in. You can really see it rise. And this is just with tidal breathing. It's quite impressive. These signs are all over the place. We see them all the time. I was told once that I would never see Kussmaul's sign, or hardly ever. You might see it once in your career. I see it once a week. We see this stuff all the time. You just have to take the time to look for it. And this is a great example of Kussmaul's sign here. Okay, this is the last video. What do you guys notice here? So what I see is a ripple up the neck that's occurring intermittently. You see it there? So right there, right there. And this is a Canon A wave in a gentleman with complete heart block. So you can see the normal waveform down here in between, but then every once in a while you see this ripple that goes up the neck. So there it is, normal, normal. There it is. There it is. This is AV dissociation. Okay, last video. We've got Russell Crowe from one of my favorite movies, Gladiator. By the way, Maximus is not supposed to be alive at this point, but clearly we can see movement in his neck. So Russell Crowe is a great actor, but he's not that great. And so the question is, do we think that this is venous or arterial, and why? And this is clearly a venous pulse. Look how diffuse it is. We have movement involving the entire neck. There's clear inward movement, and this is a venous pulse. Before we conclude, let's bring it back to Wenckebach. So how did he describe Mobitz 1 using the neck veins? Well, let's go back to the EKG. What is the equivalent of the P? What is the P wave on the EKG? Well, that is atrial depolarization / contraction. And what is that in the neck veins? Well, that's the A wave. How about the R? That is ventricular depolarization / contraction. And what is that in the neck veins? That's the X descent. So he observed AX prolongation leading up to dropped arterial pulses. Quite remarkable, but it is incredible how much we can learn and know about the heart by looking at the waveform itself.